So this is a session about changing therapies, and it is something that comes up fairly frequently, so it's a good practical topic. When we get to the question part, it'd be best if you probably don't ask questions that are like very, very specific to your own situation. But anyway, don't want you to go back and tell Dr. McGoon that Dr. Badesch said you need to change your therapy. He probably wouldn't appreciate that. So anyway, I'm going to begin discussing kind of when to change therapy, what are some of the indications that you might need to consider and things. And then got three people with me. Cheryl Abbott's one of our research coordinators from the University of Colorado. And Steve Mathai is from Johns Hopkins University. And Roham Zamanian from Stanford is stepping in for Dr. Hunter Champion, who couldn't make it from Pittsburgh. So thanks, Roham.
Thank you.
Yep. And so when to change therapy? One of the indications might be continued clinical worsening despite the therapy that you're already on. And Sherry's going to discuss a little bit about what information would suggest that you're not thriving on your current therapy and whatnot. But continued worsening, evidence of decline in exercise capacity and functional class, things like that, worsening cardiopulmonary hemodynamics, worse symptoms, and things. And then one of the things that's coming up in the field now, because we have so many therapies and whatnot, is should we be satisfied with just preventing worsening? And that's kind of been the approach historically. But actually now I think it's no longer good enough. What we'd like to see is people improving over time. So one of the other indications for changing therapy or potentially adding therapy and whatnot might be just, failure to continue to improve. So not attaining a therapeutic goal. So there's this approach, of goals of therapy or goal-directed therapy. It was advocated originally by Marius Hooper in Germany, and setting certain goals like a certain distance on the 6-minute walk distance, attainment of early functional class, limitation of symptoms and whatnot. So setting very defined goals and targeting those goals and adjusting therapy as necessary to try to get there is sort of a newer approach. And then finally, one of the important reasons to consider changing therapy might be adverse effects from therapy, side effects, toxicity and whatnot. So, for example, evidence of liver toxicity when you're taking an endothelin receptor antagonist or something like that, or excessive nosebleeds or something when you're on a phosphodiesterase inhibitor, those sorts of things. So side effects might motivate a change in therapy. So those are the kind of main things that would make me think about changing therapy. And now Sherry's going to briefly tell us about what information should we obtain prior to changing therapy.
Okay, so when you're on a therapy, in the beginning you are at a low baseline, or you're at your baseline, and then you start therapy, and now you're at a new baseline. Hopefully you've improved a little bit on that therapy. Well, then as time goes along, perhaps your baseline's changed a little bit, and you call up your physician or your nurse, and you let them know that something has changed. And some of the things that you might be telling that person on the other end of the phone is that, you're a little bit more short of breath, or perhaps you're just a little bit more fatigued lately. You're not able to do quite as much. And it doesn't necessarily have to be with extra activity. It could be your normal activity that you do day to day, and you're just feeling a little bit more fatigued. Perhaps you've gained a few pounds in the last couple of days. I don't mean over the last month, but over the last couple of days, you've gained 2, 3, 4 pounds, maybe even a little bit more. That's definitely a cue to pick up the phone and let somebody know what's going on. You'll probably see it first in your ankles, your feet, your ankles, and it'll start moving up your leg. Perhaps you're a little bit more dizzy or lightheaded with activity, or some people even get it when they're, not doing a whole lot. Perhaps now you have chest pain, and it's not your typical stuff that you remember in the beginning or that you've been having periodically, that mild sensation that you have. Or perhaps now you're having palpitations. So those are things that we want to definitely know about. When you come into the clinic and you're being evaluated, the doctor will ask you some questions about your activity and what kind of things are you able to do. And what they're doing is they're assessing what kind of functional class you're in. And the functional classes range from 1 to 4, 4 being the worst, 1 being the best. Most people fall in the 2 to 3 functional class range. Occasionally, the physician will ask you to do a 6-minute walk. If you're on a study, you might have to do it every time that you come in. But that is another way that they gauge whether you are needing another therapy. Are you improving? Are you getting worse? Are you the same? Dr. Badesch was saying that, sometimes we don't wait for you to get worse. We just, if you're not getting better, perhaps it's time to, to hopefully improve that a little bit. So we ask you to do the 6-minute walk, and we want you to do the best walk you can for that 6 minutes. So if we, take you for your walk and we, tell you to do the best you can for 6 minutes, and you just kind of plod along, because 6 minutes is an awful long time, and you want to make it to the end, it's really not going to give us as much information as if you do the best walk you can until you can't do it. Okay, so if you have to stop, and I don't mean passing out or anything like that. I've seen the look you gave me. But you guys know your limitations when you're doing the walk. And if you get to a point where you're just so short of breath and you need to take a break, it's okay to do that. The walk's not over. The time is still going. If you need to stop at that point, that's okay. You can resume when you're ready to resume. And then if you need to stop the test, of course, then you're done. It's we don't want you to go to the very end. But another thing that we measure there that's important is the Borg. It's the dyspnea index. So we want to see how short of breath, what's the maximal amount of shortness of breath that you had during your walk. So that's really important. So if you do your walk and you end up, telling me at the end that you're a 0.5 on a scale of 1 to 10, that tells me that you really didn't push yourself. Okay, so it's not really going to give us a whole lot of information. Okay, another thing that we can look at is the echo, and I know that you've been in a lot of sessions today that probably have talked to you about the echo, and one of the first things that a patient will ask the physician is, what were my numbers today? What was the number of that, of my pressures today? And the number itself, by itself, doesn't really mean anything. You all know it's an estimation. It does mean something, but it doesn't mean, it's not all inclusive. So when that number comes up and you find out that you have a lower number, though you're not feeling quite as good, what the doctor really looks at is how the ventricle is working. So if the pressure is lower, the ventricle might not be working as adequately. So you have to look at the whole echo, not just that one part. And as we go along, another part of the exam that the doctor usually does is listening for murmurs, checking your jugular veins. They might check, or they do check the RV lift, the palpitations on your chest. Perhaps you have a higher heart rate than you normally do when you come in. And some of the labs that they might check is the BNP level, the stress on your heart. And then the last thing that they do, if the echo's not looking as good as it could be, perhaps it's a question whether you're getting worse or, the other symptoms are kind of grouped together. They might advance onto a right heart cath and seeing, exactly where you're setting.
Great. Thanks, Sherry. So Steve, you want to tell us about some of the important factors when choosing a new medication?
Sure, great, thanks. So just by show of hands, how many people here are on more than one medication right now for pulmonary hypertension? Okay, so that's about a quarter, maybe a third of the patients, okay. And just again by show of hands, of you who are on more than one medication, did you notice additional side effects or new side effects when you started that medication? Okay, so about I think half of the patients who got additional therapy also noticed new side effects. So I think those considerations are probably the largest considerations or probably the most important considerations when we think about adding medications or changing medications. So I'm going to talk first just about adding a medication, then we can talk about switching classes of medication towards the end. So things you should know about medications and adding medications is that the current thought right now is that with the types of medications that are available, the oral medications, inhaled medications, the intravenous and subcutaneous medications, they're all fall into one of three classes of medications in terms of how we categorize how they work. There's the phosphodiesterase inhibitors, which work to dilate the blood vessels in one mechanism. The endothelin receptor antagonists, or ERAs, which work in another way to dilate the blood vessels, we think. And then the third class is a prostacyclin class, which works in a different way to do the same thing. So the current thought amongst the physicians and researchers who treat this, and we don't have much evidence to support this, but this is what we think, is that these medications together, if we add them together, since they work differently, they probably will work together or synergistically. So we think that together they might be better than any one individual medication. We don't know that for sure, but that's it would make sense if that were the case. However, as all of you know who are taking these medications, each medication has its own set of side effects. The things that you can expect for being on a medication like a PDE5, a phosphodiesterase inhibitor, which includes drugs like Revatio and Adcirca, would be headache, flushing, sometimes fluid retention, swelling of the legs, worsening of reflux symptoms or upset stomach. Those types of symptoms tend to be common in patients who are on those medications. Fortunately, over time, most of those go away. And I don't know about your experience, Dave or Sherry or Roham, but the vast majority of our patients are on these medications. By a couple of weeks, things are tolerable. I don't know if that's kind of what you've experienced also. Yeah. The endothelin receptor antagonists, the ERAs, are Tracleer and Letairis. And those medications, the common side effects are, again, fluid retention, sometimes worsening of upset stomach. The Tracleer has an indication that we have to check blood work every month. So those of you who are on that medication are fully aware of that. They're concerned about possibly the liver side effects of the medication. Letairis doesn't necessarily have that particular problem. It's been taken out of the recommendations that we check monthly blood work for liver damage for that particular medication. But again, fluid retention, upset stomach are kind of the two major things that we see with those medications. And then the third class of medication is if anyone's on an intravenous pump right now, they know about all the myriad of side effects you can get with these medications that are the prostacyclins, which include Remodulin, Veletri, Flolan, whatever intravenous medication you're on. Everything from headaches to flushing to jaw pain to heel pain to diarrhea can definitely affect your common side effects and affect how you feel. So those factors have to be taken into consideration. So when you are talking with your physician about how you are doing, and if the physician and you both feel that maybe you're not doing as well as you were, and the data that Sherry recommended has been collected and analyzed, and you think that maybe it's time to add a new medication, make sure to ask about the side effects and what to expect when I have these medications. What are the side effects I'm going to get, and how long are they going to last? So I think those are important things to make sure you talk about with your providers. The route of delivery is also important to consider, right? If you're on a pill and you might be taking another pill, that's one thing. If you're on a pill and you're going to inhale a medication, then you should be very clear about what that means. And I failed to talk about what inhaled medications involve, but they have their delivery is through inhalation, and it takes anywhere, depending upon the drug we're talking about, 4 to 9 times a day to inhale these medications to be effective. So that's another thing you should think about in terms of how you're going to adopt that into your daily routine. Are you able to do that? Are you willing to do that? Is this something that you're going to be happy with? And the third class would be whether you're going to try a subcutaneous or an intravenous medication. And these are important things to cover when you're talking to your physician. Well, what does that mean? And what I tend to do, and I imagine that the other providers here do also, is I try to find someone who is similar to the person that I'm seeing, who I know is willing to speak with a patient, and perhaps would be a good person to match this patient up with. And I have them discuss. I give them the phone numbers obviously with permission, and they discuss kind of what does it mean to be on a sub-Q medication? What does it mean to be on an IV medication? Because, quite honestly, we don't know. I don't know what it feels like. And I think I can tell you what I've seen, but that's not the same as having somebody who's actually been on the medication talk to you about it. And obviously that's one of the great things about having support groups and having meetings like this where you can talk about those types of things. But I think also on a one-to-one individual patient level, it's a nice thing to have open to you. And I'm sorry, Dave.
Well, Steve, I was just going to ask you, our habit has been to add one therapy on top of another, so that our patients sometimes end up on 2 or 3 therapies, and we're not sure how much benefit they're deriving from each individual therapy and things. Should we be thinking about maybe switching therapies at times as opposed to just adding? I mean, if a therapy is not showing itself to be effective, do you ever stop a therapy and actually change somebody to something else?
Yeah, I'd be curious to see what your answer to your own question is. But for us, switching a medication really for inefficacy or for lack of efficacy is infrequent. It's more of a side effect issue if patients aren't tolerating the medication. And I've not had much experience with having a patient on a certain medication and then substituting another oral medication, for instance, for that. So it's switching from Tracleer to Revatio, let's say. I've not done that as much. Instead, I would add on that medication. So I don't have much experience with that. Unless someone had a significant issue with tolerating the medication, then I would stop it. I think that's a little bit different question when you're talking about people who are maxed out on 3 medications. They're on 2 pills and they're on an inhaled therapy, and then you want to talk about intravenous therapies. Well, I think that's a different story where you're going to have them on. Obviously, we'll stop the inhaled medication. You have them on intravenous medication, and you have to decide at that point whether it makes sense to stop either one or both of the oral medications.
So it's interesting. I suspect our practice is similar to yours, where we often add another therapy. But what's the evidence that supports combining 2 oral drugs? Is there good evidence out there that an endothelin receptor antagonist and a phosphodiesterase inhibitor really do have additive or synergistic effects?
Right, and that's a great point. And I think that there's our understanding of how these medications work together and what benefit is derived from them is actually quite limited. And I think actually, the goal-directed therapies that you mentioned before, the goal-directed algorithms, while in theory they sound great, and I actually think that they might make sense, there's actually not much data to support that that's the way to go either. So I'm not exactly sure what the right answer is. What we've done recently that looked at some data from a clinical trial that had patients who were both on one therapy and patients who were already on one therapy and got an additional therapy. And we looked to try to define what a significant change in the walk distance was related to a quality of life. So for a particular change in quality of life, what did that translate to in a change in walk distance? So someone feeling better, what does that mean? How much distance does that cover in a walk test? And what we found was that the differences between these between patients was about 33 meters. But interestingly, that didn't change whether you were on one drug or whether you're on 2 drugs. So it suggests that that difference, regardless of whether you're on one drug or two drug, is still around that particular that one number of 30 or so meters. So I think that's kind of a signal that that's maybe what we should be looking for as one potential metric to assess whether or not you're responding is of a change of about that magnitude.
So I wonder if one answer might be in a patient that's not rapidly failing to consider enrolling them in a clinical trial of add-on or combination therapy, right? So we can learn whether or not additional therapy is truly a benefit.
Yeah, I think that's a great idea.
Yeah.
That's a great point.
So, all right, Roham, what do we want to monitor after changes in therapy are made? How do we assess the response to a change in therapy?
Yeah, I think that's a really good question, and I think fits nicely with the conversation here. I think it's a natural continuum. So the first step is to consider how significant of a change there's been in medical therapy and how concerned the clinicians we are in terms of the response and how quickly we want to see that. If a patient is admitted into hospital and started on a newer therapy and we're worried about that, our general practice is to see them 2 weeks after, but more frequently is to have a follow-up visitation to evaluate some of the tools that have already been discussed. Often, depending on the nature of the therapy that's added, we like to follow up patients in a month or two after the initiation of therapy, sometimes maybe 3 months if they're fairly stable, and re-engage in the conversation again, the same conversation that you all had when the medication therapy change was discussed. How are the symptoms? How are the symptoms improving? How are you tolerating the side effects of the medications? Are the side effects of the medications something that we anticipate or not anticipate? We like to evaluate functional class. So before you were winded with minimal exertion, has this medication begun to change that activity class for you? And our expectation would be with an effective therapeutic change, that it would be effective changes or stabilization of those sort of symptoms. Some of the medications, such as some of the endothelin receptor antagonists, need us to be assured that there is no gain in weight or fluid retention that can paradoxically go along with that. So we would gauge the same symptoms in terms of that. And then, obviously, as Steve talked about, some of the safety laboratories, liver function testing that needs to be done. We need to make sure we follow that and monitor and see the response. But also, in terms of laboratory, one would want to see gauge of improvement of efficacy laboratories. There's a lot of debate about following levels of NT-proBNP, which is a cardiac hormone that may relate to the degree of cardiac dysfunction in pulmonary hypertension. We want to see maybe some changes in that, although those are sort of more experience-based than really standard of care. But you basically are employing the same tools that you did to make the change occur, to see that those parameters are moving in the right direction. I can't highlight enough, I think that one of the experiences that was very interesting to me and actually very important was sometimes symptoms that mimic worsening pulmonary hypertension aren't the pulmonary hypertension themselves. I had an unfortunate situation of having a very young, long-term idiopathic patient on Flolan who was getting more and more winded. And she had really very end-stage findings, and we decided to increase her therapy. And the increase in her prostacyclin, she didn't respond very well to that. As a matter of fact, her symptoms didn't get any better. Then we realized that her symptoms of shortness of breath were because of a primary lung cancer. So, not to say that that's the thing, but we want to make sure that our evaluation, you're always considering the change of response to the medications. And then you really want to talk about some of the conversations that you already began with. Are you able to tolerate, are you able to keep up with the frequency of the dosing of the medication? Has that been a problem specifically or not? So then finally, I think that imaging and echocardiography is in our toolbox, and there are places where if a patient is considered high risk, then routine or earlier evaluation by right heart catheterization is employed. So at our center, we try to institute right heart catheterization as a routine and follow-up, annual or biannual, or every 2 years. But certainly with the therapy change, we might want to visit that consideration and looking at has the right heart function improved. So I think there is a lot of the extension of the process that begins with the decision to change, the decision to change to a certain therapy, and then re-employing the same tools and same conversations to see an expected achievement of change. And I think that some of the conversations are about being very aggressive and knowing when to employ, as was discussed, more aggressive forms of therapy, in essence, going quickly when we feel that a patient is deteriorating. So
That's great. So those were all nice presentations. I think the room is warming up, don't you? Yeah. You all look like you're going on a sleigh ride. So going to open it up to questions now. Yes.
About how long of a time span do you give before you do another right heart cath after you've added another medicine to make sure to see?
Maybe I can start off with that. Yeah, so let's, I think it's sometimes very specific. I think one might say that in general, I would consider 4 to 6 months time, sort of a zone where we can think about that. Now, if we initiated intravenous prostacyclin, and because of side effects, it's taken a while, and you're back at 4 months, and you're maybe 10 nanograms per kilo per minute, we might not expect the maximal response. So I think that there's nothing like a magical number to it. I think if I'm more worried, I do it sooner, because the reality of it is, and the conversation we also have with advanced patients is that at our institution, I'd be interested in what you guys do. When we go triple therapy, we begin to talk about transplantation. If that's because that may be the next step. And so there is a window that we want to be sensitive to. So if you're on, that's your triple therapy, and you're within the transplantation window, and I may do the right heart cath a little bit earlier to either maximize the therapy or to have a conversation back with you and say, this is the therapy, this is what we have achieved or not achieved, these are the conversations we need to have. I don't know what you guys do, Dave and Steve.
Same thing. Yeah.
Do you all know when we were talking about triple therapy, what we're referring to? No? Okay.
Yeah.
So triple therapy means, at least I hope we're talking about the same thing.
I'm not talking about cocktails, thanks.
Okay. So we're talking about an oral endothelin receptor antagonist, an oral phosphodiesterase inhibitor, and an inhaled prostacyclin. Okay? So when people are on that combination, the stepwise approach would be, well, you started with one drug, we added another drug, and then what Roham is saying is that at that point, that's when we start thinking about, if you're on those three therapies, that's when we start thinking about IV therapy, and we also, in tandem, would think about lung transplantation. So that's the kind of, that's what we're talking about.
Steve, do you always make that progression through inhaled therapy before you go to IV therapy in prostanoids?
Yeah, so that's probably a broad generalization. I think that's a good point. Some of it does depend upon patient preference. I think some patients want to try the inhaled therapy before moving to intravenous therapy. I think it's a reasonable decision. Other people say, you know what, I don't think I'm able to do it 4 times a day or 6 times a day or 9 times a day or whatever. I think I want to go on the pump, or I want to, and that's kind of a discussion that I have on an individual basis. But in general, our general practice would be that we would go through that algorithm. If patients don't want to be on the inhaled therapy or can't tolerate it, then obviously we would change it.
Okay. Another question?
Yes. Have you had any success in switching any patient from pump into pill prostacyclin, oral form?
Well, there's no pill prostacyclin available in the United States. In fact, I think the only pill prostacyclin preparation that's available commercially in the world is Bariprost in Japan. So our ability to make that transition is very limited. I've got no experience going from IV to pill prostacyclin. If you ask the question more general way, do people ever come off of intravenous prostacyclins? I suspect maybe that's part of the question. That can happen rarely, I think. There are very rare patients who do extremely well on intravenous therapy and actually normalize their hemodynamics, normalize their exercise tolerance and whatnot. And in that situation, it may be reasonable to get them on some other form of background therapy and then attempt to gradually wean the prostacyclin therapy. That can be done, but it needs to be done very cautiously, and I think it's only fairly rarely successful in our own experience. Steve?
Yeah, so I would ask you a question, kind of the reverse of that. So I know that some centers advocate the opposite approach that we've discussed up here, where we're starting with one medication and adding another and adding another. Some centers do the exact opposite. Someone comes in and they'll hit them with intravenous therapy and oral therapies and then remove them one by one. And I'd be curious about your take on that. Have you had any experience with that clinically, and what are your...
That's a great question. We do tend to be quite aggressive with patients with severe disease, so that we might begin with an intravenous therapy when somebody comes in high functional class 3 or class 4 disease, the patients often don't like to begin with intravenous therapy, but I think if they're severely ill, that's the most appropriate approach. And then actually, this very aggressive upfront therapy is currently under study in France, as you know, where they're looking at what they call upfront triple combination therapy, where a patient has begun right from the get-go on an endothelin receptor antagonist, phosphodiesterase inhibitor, and a prostanoid. And, they've reported some pretty remarkable improvements, I think, in hemodynamics and performance and whatnot in a small number of patients in an uncontrolled trial. And it is provocative. I mean, I think that we're interested in that possibility. In a lot of diseases like cancer and left-sided heart failure and whatnot, they tend to start with a very aggressive regimen up front. Where you have induction chemotherapy, for example, for an aggressive malignancy. It's induction chemotherapy followed by a kind of tapering of therapy to maintenance therapy over time with a less aggressive approach. It is sort of the opposite of what we've tended to do in pulmonary hypertension, and it's come up. Should we be taking an approach more like that with our patients with more severe disease? Rohan?
Yeah, and just one last caveat of the question. The next question you would ask is, I think we've actually begun to answer that, is IV therapy to inhaled prostacyclin. And so I could share that we have a paper in press that looked at 5 or 6 different centers that went from any form of intravenous therapy to inhaled Remodulin, and we found that was not an optimal approach. As a matter of fact, that patients who were on IV therapy were high risk enough or sick enough to some extent that they required that, and when they went down to an inhaled therapy, several failed that conversion. So we speculated, and I think the reviewers agreed with us, that sort of step down therapy or change from intravenous to inhaled, at least, is not for everyone, and it should be done in a very careful, controlled setting. So unlike those patients who normalize their hemodynamics, I think the applicability of going from intravenous to inhaled or even oral, I think that's a little bit more, needs to be carefully studied.
Yep, agreed. Other questions? Yeah.
My question is, I'm a calcium channel blocker responder, and my question is, how frequently do CCV responders eventually have to go on to the other types of therapy in your...
Okay. So the data on this is, there's one study that looked at this and found that patients who are calcium channel blocker candidates, and are you all familiar with that? So when you're doing the evaluation, for initial evaluation for pulmonary hypertension, you have a vasodilator challenge. If during the catheterization, if there's a specific drop in the pressure that's seen without a drop in the cardiac output, then you're considered a a vasoresponsive patient, and you can respond to calcium channel blocker medications. So what this group in France looked at was the patients who responded in that way. And what they found is about 10% of patients with idiopathic disease had this response. But over the course of the first year or so following that, on follow-up catheterizations with the vasodilator challenge, they saw that half the people lost some of their vasoreactivity and eventually needed to go on additional therapy. I'm not aware of follow-up data beyond that first year follow-up catheterization. Dave, I don't know if you're familiar with any additional information regarding that.
No, I think, the long-term data on calcium channel blockers is that most people that have a truly favorable response, as Steve's defined, will maintain that response for quite a number of years. Yeah. Not everybody does, and it is important to continue to follow them. But usually it's a sustained response. But it's a small number of folks, as he said, maybe 10%.
And I think what happens is if you make it through that first year and you're still responsive, I think our clinical experience is that you're likely to remain responsive. But the question is that true? And I don't think we have enough information with serial catheterizations on a number of patients. We're talking about a rare disease and then 10% of those patients. It's kind of hard to study that, but I think that's what the data suggests at this point.
So I've got a question here for Sherry real quick. You thought you were going to get away. When we see our patients in clinic and they're on, one therapy and whatnot, what happens before they even come into the clinic as kind of part of a screening process, if you will?
Well, as being a research nurse, of course, my job is to screen everybody that comes in to see if they're potentially eligible for studies. So at the University of Colorado, when you walk in, or when we know that you're going to be walking in the door next week, I spend hours upon hours screening all the patients coming in the door and alerting the physicians before they go to clinic that we have potential subjects for particular studies. So a lot of the people from the University of Colorado see me, kind of marching down the halls and tapping the doctor on the shoulder to tell them we got some studies here.
So we take this research thing very seriously, and like we said, the combination or add-on therapy, it's something that really needs to be studied carefully. And so I'm sure that same thing happens at all of your centers.
We have a weekly meeting a couple days before clinic, and we go through all the patients that are coming in and do the same type of process.
Yep. Okay, another question? Sorry.
Yes. Do you have any experience with a patient who did not improve on Tracleer having positive effects from Letairis?
Anybody want to take? Okay. We haven't switched back and forth from one endothelin receptor antagonist to another very frequently. And I don't know that I can answer that in any kind of organized way. There might be occasional patients that'll respond to one, not to another, and things. Some patients might have demonstrated liver toxicity on one agent and then not demonstrated on another. There has been a clinical trial that has shown some of that too, I think.
I don't think there's a biochemical reason based upon the way the molecule, the medication is made, but there would be a significant difference potentially in the response in terms of pulmonary hypertension. But, every patient's different. So that's one of the challenging things about pulmonary hypertension.
I have had patients who we've stopped their Tracleer because of liver toxicity. This is before ambrisentan was available, and they felt worse than once you reintroduce the ambrisentan because of the liver toxicity issue, that sort of brought them back. So sometimes we get patients who are on Tracleer, for example, that don't feel like they're necessarily continue to improve, but they're stable, and then you take them off for a reason. So like David was saying, the switches, but there isn't any data around that.
Yep. Other questions? I know you have one in the first row.
On Flolan at first, and now I'm just on Revatio and Tracleer. I was weaned off of the Flolan after 8 years, and I feel great. So I'm one of your ones over here in the corner that.
That's terrific.
Yeah.
Wonderful.
Yeah.
Yes.
I'm just trying to understand a little bit. With the 3 treatments, with the 2, like Revatio and Letairis, and then if a third medication has to be introduced, are you saying that it's, because I'm in a position now where it's debatable whether I do the inhaler or the sub-Q. So are you saying that it's usually start with the inhaler versus the sub-Q, or patient preference?
So I get the impression there's a bit of a difference of opinion among the panelists, perhaps even on that issue. I'll tell you, my own approach is if a patient truly requires the addition of a prostanoid, is not doing well despite 2 oral therapies, my general preference would be to go to an intravenous prostanoid, which I consider to be the most effective therapy available. But I recognize now there might be a difference of opinion here.
No, I wouldn't necessarily. I don't disagree with you. I think in my practice with my patients, there seems to be reluctance to progress to that without trying the inhaled therapies if they can. And some patients will say, no, I don't want to try, I just want to go on the intravenous medication. We haven't talked about the subcutaneous medication. I would kind of, I'm not sure where to put it. It's kind of in between, I think, the inhaled medication and the intravenous medication in terms of its efficacy, potentially. But I don't know what your experience is with going from 2 oral therapies to adding the
well, Rohan, what's your approach?
Well, I think we have to sort of put the thing down that, to my knowledge, there are no clinical trials that have looked at the addition of a third agent on top of double agents, especially prostacyclin. So it's not like we're debating the results of a clinical trial. We're debating expert experience, right? So I think that I agree. The optimal for me is when I'm thinking about adding a third agent, which is a prostacyclin, I'm again beginning to worry about, do I need to be thinking about transplant, or what does this mean? And we have an honest conversation. We say intravenous prostacyclin is an option, inhaled prostacyclin is an option, but these are expert opinions. And I think that what we do is we take the severity of the illness and guide the patient through that. And if I'm worried that there's been substantial progression and that I'm potentially going to think about transplantation in the future, in the near future, then I try to guide that person to a parenteral or IV prostacyclin. There are patients who are very reluctant, and you all can give us feedback because you have to wear this thing around your waist and the line infections and the side pains. So some patients say, I know what that is, I know you prefer to give me that, but I want to try to inhale. And then we set, as I was mentioning before, then we set benchmarks. Then we say, okay, in 6 months, if you're not feeling X, Y, and Z, then we have to come back to this conversation again.
Okay, so now after you add the third medication, and 6 months pass, great improvement. Year pass, you do the cardiac cath, tremendous results. The means is down, etc. So you start deciding that removing a medication. So now, do you remove the Revatio, Letairis?
I say a year or 6 months isn't long enough.
Yeah.
It's not long enough?
Yeah.
Okay.
I mean, the patients, I don't know, you said you were on for 8 years before you were? Yeah. I mean, I would say stability for years, not months before I'm willing to.
I'll tell you the example. One example that I've removed someone from IV prostacyclin. I don't mean to cut you off.
I know.
I do this all the time to him, but he does it to me too. So,
keep on touching me.
My patient was on 95 nanograms per kilo per minute of Flolan for 9 years and came in with hemodynamics and a normalized echo, which Dave alluded to. That's the patient we transitioned over to Revatio and has done well. She was also a lupus patient. We thought her lupus was better managed as well. So it's very rare. There's very few conditions that I can think of myself doing that, because the other side of the coin is we don't want to miss that window of opportunity. If you're stabilizing on the prostacyclin, if I take you off and you worsen, then some of us feel that a step down is you'll never catch up with that loss of capacity sometimes. So we revisit the medication, and then all of a sudden your transplant candidacy, and I don't mean to keep saying the T word, but we have to think about the future of things, and we don't want to jeopardize that.
So I'm stuck.
Yeah, well, I think it's a very personal decision between you and your physician to kind of decide what makes most sense for you, what you want, what your goals are, and what the physician advises you regarding how best to achieve those goals. Yeah. One thing I think is kind of interesting too, if I may interject just for 1 second, is, I think there are a lot of patients and that I've experienced, I'm sure that you all have had this experience, who are very reluctant to go on the pump. And as I said, I don't have a pump, so I can't explain. I don't pretend to know what that feels like. However, if you look at the literature about quality of life in patients with pulmonary arterial hypertension, what do you think is the least favorite part about all what we do to treat patients who have pulmonary hypertension? Sorry? No? Well, sub-Q wasn't available during the study, so that's not the flow line. Not the flow line. Nope. The oxygen. Oxygen was the only thing that people on flow line, they had no difference in quality of life. It was the patients who were on oxygen. That's what they hated the most. So, I tell you that because I think that some people are very reluctant to go on the pump, and then other people who have been on the pump will say, you know what, yes, it is a hassle, but you know what, I feel great on it. So I think that, you should, that's why sometimes it's very helpful to talk to other patients who are in that situation, who have had the experience, so you can learn those things about how life is with wearing a pump.
Okay, another question?
I did, okay. I guess I must be an odd case or something, because I had no symptoms really, shy of shortness of breath mildly, but they immediately put me on the IVN at Circa. Recently they want to put me on the Lateris also. So all of this learning is going to be my decision, obviously, and discussions with the doctor. But I'm going actually back to the calcium channel blockers. If during the cath you weren't receptive to it, does that medicine help you in any other way? Because right now I'm also on a beta blocker, and of course not to get the medical, diagnosis, but so don't even bother, going that direction with a calcium channel blocker instead of a beta blocker or something.
I think I get the question.
I'm sorry, I was just going to say, am I making sense with that?
I'll try. I think you're asking, if you are not vasoreactive in the cardiac catheterization, does a calcium channel blocker offer you any other benefit aside from the usual with pulmonary hypertension that is vasoreactive? And I don't think so. I mean, occasionally calcium blockers are used to treat things like they treat systemic hypertension, Raynaud's phenomenon occasionally, things like that. But or maybe if you have a fast heart rate, you might use a calcium blocker to help slow that or block it down. But I don't think that if you were not vasoreactive during the cath, that there's any clear indication for using a calcium blocker after that. Is that your own?
Yeah, and I actually try to get patients off of calcium channel blockers if there's no indication. Mm-hmm. Because there's at least in my experience, I'd be curious of your experience too, there can be negative effects on the squeezing function of the heart from calcium channel blockers. So, if someone's on a calcium channel blocker at a higher dose, it's not just for, typically for Raynaud's, it's a low dose, which I think is okay, but if you're on a higher dose of the medication, I try to get them off and give an alternative medication, even for a fast heart rate. We don't use calcium channel blockers to control heart rate.
So, Zemania, are you going to agree with Mathai this time, or what?
That's right.
Yes, I'm going to agree with him, but I'm actually going to extend that because I think sometimes calcium channel blockers lower the blood pressure to the point that we can't add further therapies because things like tadalafil and Revadio reduce your systemic blood pressure to a little bit of an extent. But so you want to remove the calcium channel blockers as best you can.
And one final thing is calcium channel blockers can also interfere with the lungs' normal response to low oxygen levels. So it's called hypoxic vasoconstriction. The lungs are the only organ in the body where when oxygen levels get low, the blood vessels constrict. That's why we want patients who have pulmonary hypertension who are hypoxic to wear oxygen, because we think that relieves that vasoconstriction. Because blood vessels constricting in the lungs makes pulmonary hypertension worse. So these medications like calcium channel blockers can interfere with that normal response to medications and potentially worsen BQ or matching of oxygen and carbon dioxide and potentially make the situation worse. So in general, I don't like calcium channel blockers unless it's a patient who's truly vasoreactive.
All right, another question? Yes.
I wonder what your thoughts and experiences are on transition from Flolan to Remodulin.
Interesting. That's one that I personally don't make very often. If somebody's stable and doing well on one intravenous prostanoid therapy, I tend to continue that.
I've done it really twice for patients who had a very low amounts of platelets, because there's some evidence to say there's less of, but that's the only time I've really done it. Typically that isn't a common change, except if it's for if one decides to go from a intravenous to subcutaneous, although I don't know why one would do that. But
I think a couple years ago, before other formulations of Flolan were out there that were room temperature stable, there might have been more of an issue to do that, more of a reason to do that. I think now with all the different formulations of Flolan that are out there, it's less of an issue in my opinion. I don't know if you feel the same way.
Agree. Yeah.
It's a confounded thing. So we know that severe pulmonary hypertension patients and sometimes those with prostacyclin have lower platelet counts. And it's, at least to my experience and my reading, it's unknown whether that's because of the severity of the pulmonary hypertension to some extent, or that the fact is that the prostacyclin is causing it. So there are instances for us where the platelets got very low and there could be some bleeding complications that we decided to change the patients. This was probably 5-6 years ago, from epoprostenol Flolan to Remodulin. And I think that the difficulty there, to be honest, and I think another aspect of this is we don't know exactly the dose conversion of these medications. So you would sort of be trying to guess, although some people feel like they sort of know what the range is. One of Flolan is not one of Remodulin. So it's a little bit of a difficult thing. But there was some thought that Remodulin has less effect on the reducing the platelets, although this could be very confounded because it's a very severe disease that could cause that as well.
Okay. Yes.
Okay, my question is, I'm on all three. I'm on Tracleer and just recently taken off of Revadio and put on a Circa, and I'm also on sub-Q. My thing is, I started sub-Q 3 years ago. I weighed about almost 200 pounds. I've gotten really sick from it. I've gone from 80 nanograms, I'm down to 40, and I still continue. When I change the site, no appetite, nausea, and I'll go down to like 110 pounds. And at any time, would you guys consider taking off of Remodulin? Because my doctor says, let's just watch and keep watching and keep watching and keep watching. And there's days that I feel like I'm going to die from weight loss, not from IPAH. So how would you deal with a patient that, it's working. It's brought my pressures from 131 down to 52.
I think we have to be careful about providing individual advice, without understanding your entire situations. I'd be careful there. But we dose the medications to a patient's tolerance in a general way. And so when a patient begins to develop intolerable side effects like nausea, loss of appetite, weight loss, things like that, we would tend to back off on the dose. And that's in a very general way. I'm not offering you specific advice, but
I totally agree. And sometimes your physician needs to spend time with you to dissect whether those symptoms are side effects from the medication or other things that are causing it, medical conditions or pain that's affecting you. So I would sit down and get to the cause of your symptoms first.
So, other question? Yes.
Dr. Rohan, I was wondering if you could further elaborate on when you talked about the window. So if a patient is already on the three treatment, including the intravenous. But the patient is stable and their numbers are looking good. Would they? Is that the window that you're saying now that they're stable? We should be thinking in the future about the transplant.
Well, so let me tell you. I mean, I think that, again, this is very center specific, and I'll tell you what we do at our center. And we have a lot of experience with transplantation. We have an active transplant program. So with transplantation, there is an initial tremendous amount of workup that needs to be done for the patient and education about transplantation, because just because one gets a transplantation may mean that you get resolve your pulmonary hypertension, but you're stuck with another chronic illness, transplantation. So there is a window of opportunity to educate the patient, to meet and greet the transplant team, and as well as having some of the basic workups to recognize whether you will be or ever not be a transplant candidate. So we feel like once our patients are on triple therapy, we're not saying that you're going to need a transplantation, but that we should introduce you to our transplant team as a consultation. But there are patients, and it depends on their medical condition, that we worry a lot about them, and we worry that the disease is progressing so rapidly. Sometimes when the third medication you're adding is not a prostacyclin, it's an oral therapy, and so it's not very usual that we end up adding the prostacyclin at the end, which we think would have the biggest bang for the buck. But essentially, we risk stratify our patients. What are the etiologies of the disease, and what do we know about how quickly they've progressed? And we introduce them to the transplant team because of those concerns. So there isn't anything that guides us on when is the right time to transplant a pulmonary hypertension patient. But the real effect is that even today, although that may change in the near future, pulmonary hypertension patients, when they go on a waiting list, have a substantial amount of time they have to wait for lung transplantation. So we never want to get in a situation where it's, fourth down, last quarter, and we're going to throw a Hail Mary. We got to get there before that happens. And so it's part of the preparation. Not to say we can't have urgency to the workup, but it is a process, and so I think that it's a conversation that you need to have with your physician. There are points where pulmonary hypertension patients get to a place where they are no longer a transplant candidate, and depends on the transplant program. Our program is very, very conservative. They might not consider you a transplant candidate if you have renal kidney dysfunction. So these are all the bigger conversations around that. So it's not that you go on triple therapy and, oh my God, but we have to begin to put that out and begin to think about it as professionals and our patients. I don't know what everyone else says.
Yep.
Yeah.
Sounds good. We've got time for one more question. Yep. Go ahead. The BNP level?
Yeah, exactly.
Not the gross national product. We'll talk about that.
The GNP?
BNP is brain natriuretic peptide. It's a circulating substance that they measure to give you an idea of kind of degree of heart failure. It has been shown to correlate pretty well with left heart failure and more recently with right heart failure and even disease severity and pulmonary hypertension. And it may even be a pretty good prognostic indicator in some folks, I guess, if you track it over time. Is it?
Yeah. The way I explain it to patients is it tells me if there's a stretch on the right side of the heart. So if the heart's being stretched, it's released in response to stretch of the heart. So if the right ventricle is dilated, one of the ways we think is we can track that, not only by echo, but looking at the BNP or pro-BNP.
All right. Well, thanks very much. You all have a nice afternoon.